Greetings everyone, and welcome to this webinar provided by Doctors Data. Doctors Data is a premier specialty lab that provides a vast array of advanced laboratory tests to forward-thinking clinicians around the world. Now, my name is David Quigg. I am the Vice President of Scientific Support for Doctors Data. Now, by choice, I am not a licensed clinician because as a nutritional biochemist, my passion has always been to provide consultations and educational materials to clinicians. I really enjoy translating the hard science to busy clinicians, and I have been doing such for 20 years. Now, today I will discuss the many components of our truly comprehensive stool analysis, emphasizing the clinical benefits of going far beyond just doing microbiology and parasitology. Now, when we think about the gastrointestinal microbiome, we really have to think about it as an ecosystem, because every ecosystem is a network of interactions among and between organisms and their environment. And in the case of the gastrointestinal ecosystem or microbiome, the environment also includes the host that is carrying around this huge microbiome. But we always have to keep in mind that, as Claude Bernard back in the 1800s said, the germ is nothing, terrain is everything. So we have to also consider what's going on metabolically in the microbiome, which affects everything that happens not only within the bounds of the intestines, but also throughout the body. Now, just to get us all on the same wavelength, the microbiome is composed of the microbiota, all the microbes, plus their genetic material. Whereas the metabolome, which is of much greater interest to me as a biochemist, includes the microbiome plus its collective biomolecules or its metabolic products. Now, these microbial metabolites consist of intermediary and final products, including cellular constituents, such as the lipopolysaccharide molecule that is very abundant in gram-negative bacteria. Now, these intermediary final products and cellular constituents all can have either positive or negative effects on not only the gut, but also systemically, including the central nervous system. Now, the importance of gastrointestinal health on systemic health has been recognized for a very, very long time. A very wise man named Hippocrates back in 400 BC stated that death sits in the bowels, and bad digestion is the root of all evil. Well, about 2,400 years later, another really smart guy, Dr. Jeremy Nicholson, pretty much the king of the metabolome, has stated very similarly that every sort of disease has a gut bug connection. And within that, he included everything from inflammatory bowel disease to vascular disease, autoimmune, inflammatory diseases, asthma, eczema, depression, and even possibly the autism spectrum disorder. So the indications for stool analysis, we're all familiar with the basic GI issues, loose stools, diarrhea, constipation, gas, bloating, indigestion, and IBD, but we also have to think out of the lumen, out of the gut, and think about the systemic conditions such as asthma and allergies, the effects of stress, raising cortisol, decreasing lactobacilli and secretory IgA, diabetes, carbohydrate sensitivity, food sensitivities, atopic eczema, arthritis, and ASD, ADD, and ADHD. Studies have shown that when we compare children on the spectrum to neurotypical children, the dysbiosis is present at about 91% in the autistic children versus about 25% in the neurotypical children. So there's all kinds of indications for stool analysis beyond the gut. So why comprehensive stool analysis? Well, obviously we want to identify bacterial imbalances, pathogenic bacteria, yeast, and parasites, but also we want to know about digestive and absorptive functions, inflammation, the status of the gastrointestinal short-chain fatty acids, which I will discuss in detail, the gastrointestinal humoral immune function, that would be secretory IgA, pH of the stool, and other biomarkers of gastrointestinal health. And we do that so that we minimize exposure to GI-derived toxins, such as the lipopolysaccharide endotoxin, and to optimize digestion and absorption so that we can enable optimal nutritional status, and that in turn enables optimal endogenous or innate detoxification processes, which are inducible given the right nutrients and botanicals. Now, identification of bacteria, yeast, and viruses can be performed by several different modalities. The latest and greatest has been the high throughput deep gene sequencing, also known as metagenomics. And someday, metagenomics should be clinically interpretable. Right now, have identified over the past 10 years or so about 3 million microbial genes. And it's important to keep in mind that this genetic material or information actually complements culture, but a severe limitation is that it does not permit susceptibility testing. So we really don't know the phenotypic expression of all these different bacteria that we've categorized their genetic material for. Then we have multiplex PCR, which has come a long way since basic PCR. It's extremely useful for pathogens, bacteria, parasites, and viruses, but it's limited by the number of validated probes used in the PCR process. And in fact, PCR can be too sensitive in some cases, particularly when the results are simply reported as positive or negative for something like C. difficile. So a huge issue with PCR, even in the FDA-approved methods now, is that there really needs to be very significant education of the clinicians on how to interpret these tests and match up the symptoms with the results, because one can have residual DNA detection weeks after a parasite, or even C. diff has been eliminated, and we don't want to be treating patients unnecessarily just based on a very sensitive PCR result. The other limitation with PCR is that, like metagenomics, it does not permit susceptibility testing. So the question asked by multiplex PCR is its DNA present? And in fact, another question that needs to be answered by that is how much DNA, and is it in fact dead or alive? Again, we don't want to be treating patients unnecessarily for residual DNA that's detected by the PCR. And then we have the tried and true tested non-traditional microbiology with proteomic identification of the microbes. And the old saying was that the vast majority of gastrointestinal microbes cannot be cultured. But speaking with many renowned microbiologists, the more accurate statement should be that most gastrointestinal microbes are not routinely cultured. And if you want to enlighten yourself further and find support for what I just said, do yourself a favor, and sometimes when you have spare time, just Google the term culturomics, and you will be absolutely impressed by what you can find using high complexity culture followed by the proteomic method of identification. So culture and identification also is very important because it permits susceptibility testing, that is the phenotypic expression of the bacteria and yeast that you've identified. Resistance to pharmaceutical and botanical antimicrobial agents is just outpacing the ability to come up with agents, and each patient's bacteria, yeast, need to be tested for the phenotypic expression, the resistance to or susceptibility to the different agents. So unlike multiplex PCR that asks, is it present? What a culture and identification ask is what is alive and present or absent. Now, admittedly, ideally, clinically, a combined approach would be most optimal. So, at Doctor's Data, we perform non-traditional microbiology. Most traditional microbiology is conducted using just 3 different growth conditions. But we use a total of 10 growth conditions, 5 aerobic, 3 anaerobic for those microbes that are very, very sensitive, obligate anaerobes, sensitive to oxygen, and then 1 condition for microaerophilic, those that can tolerate low levels of oxygen, as well as a yeast-specific culture condition. Now, after we culture these microbes, obviously we have to identify those. And here we have the entrance of the revolutionary technique in clinical microbiology, that is MALDI-TOF MS, which stands for Matrix-Assisted Laser Desorption Time-of-Flight Mass Spectrometry. Now, what this technique does is it identifies microbial species by their unique protein fingerprints, and it does such in less than a minute. The older biochemical techniques required 6 to 24 hours. Currently, using the vast reference database, there's potential to identify over 1,200 gastrointestinal species. Now, some of the, we've identified using this technique an additional, quotes, species from patients, and that includes 400 species of bacteria, most of which are commensal or what we call value-driven commensals, and then also 100 different species of yeast, including 65 Candida species. So just to give you a quick view of the way that MALDI-TOF MS, time-of-flight MS works, the clinician takes just a portion of an isolated colony forming unit, embeds it within a saturated matrix on a target plate that stabilizes the proteins and imparts a positive charge. The target and the matrix are then dried, and then the specimen is bombarded with nanosecond pulses of laser, which causes desorption and ionization or vaporization of the proteins, which then fly through an electronic field that's under vacuum, and the proteins fly through the tube inversely proportional to their mass. So the smaller proteins reach the mass spec detector at the back end of the instrument before the larger proteins, and that enables separation of the different protein peaks by the mass spec. And then the unknown peaks are immediately compared to the reference database, the peaks for known microbes in the database. Now, the size of the database is very important. Some labs only use an FDA-approved database, which contains about 400 species or so. But Doctors Data uses the largest reference database available, which is greater than 1,200 gastrointestinal species of yeast and bacteria. And using this method, we were able to identify the first case of a Laribacter hongkongensis as acquired in the United States. This organism was identified in Europe, Africa, and even Australia in the past, but it's never been identified in the U.S., and that's because the older techniques did not have the ability to identify this bacteria. And we were very proud of this identification. The identification of Laribacter was in fact confirmed by 16S RNA pyrosequencing, and this work was in fact published in the very prestigious Journal of Clinical Microbiology in 2015. And if you're really into microbiology methodology, this is a great read. Clinically, it's not very exciting. So the first thing we do in our comprehensive stool analysis is look at the bacteria by culture as described. And there are several different types of dysbioses, and too often overlooked is insufficiency dysbioses, where we see markedly suppressed colonization of a host of beneficial or commensal bacteria. This results in a compromised mucosal barrier due to the vacated adhesion sites, which enables other bacteria to come in, and very importantly, due to the decreased butyrate production by the commensal bacteria, which regulates microbial host crosstalk, the regulation of the secretion of secretory IgA, antimicrobial peptides, and mucus and mucin secretion, which all results in a decreased mucosal mucus layer permeability, or increased mucus layer permeability, compromised mucosal barrier. Now, with such insufficiency dysbiosis, we often see many commensal bacteria, most of which are just benign. Some have properties such that they're redundant and help do the job for the missing beneficial bacteria, but others are not so nice, such as Acinetobacter radioresistens, which in fact secretes a secretory IgA specific protease. So it has an ability to knock out one of our first line of defense in the gastrointestinal tract. So with such an insufficiency dysbiosis, a compromised mucosal barrier, it's not unusual to consider this as a train wreck waiting to happen, where ultimately we get overgrowth of dysbiotic bacteria. But it's important to keep in mind that just the insufficiency dysbiosis and the bacterial imbalance can be associated with not only gastrointestinal symptoms, but even systemic conditions, even in the absence of pathogenic species. Now, this train wreck often results in the overgrowth of dysbiotic bacteria, in this case Klebsiella pneumoniae, species pneumoniae at 3+, and Klebsiella is a gram-negative bacteria that is very abundant with the cellular constituent, the lipopolysaccharide endotoxin. There's estimated to be about 1 million copies of LPS per cell of gram-negative bacteria, and this really becomes problematic when we have increased intestinal permeability, especially through the zonulin activated pathway of breaking the tight junctions. Now, this lipopolysaccharide LPS endotoxin is very pro-inflammatory. It also inhibits phase 1 cytochrome P450 activities, and phase 3 efflux pumps, so detoxification is affected, and it also impairs methylation, which we will discuss at a later date. Now, many of these imbalanced bacteria we consider to be value-driven in that when they are present at greater than 2+, they are transferred into the dysbiotic flora category. But you're flat out always pathogenic bacteria such as Aeromonas cavii are always reported as pathogenic, even at a level of +1 or +2. And anytime we identify a dysbiotic bacteria, of course, we do susceptibility testing. We happen to use the highly standardized disk diffusion method. So every patient's dysbiotic bacteria is tested for its resistance to a host of pharmaceutical agents, as well as to a host of natural antimicrobial agents to help guide clinicians in their treatment. There's just no shooting in the dark. It's not very effective. Next thing we move to is the culture of yeast. Looking at mycology, we use culture and microscopy. With our MALDI-TOF library, we can identify 170 different species of yeast, including 65 Candida species. Here we see a typical profile that we might see in an autistic child with significant yeast overgrowth in the Candida genus. And we also look for the yeast under the microscope. Now, when you see Candida overgrowth, it's not unusual to see very low levels of secretory IgA, and that's because in the published research, 38 different Candida species isolated from patients with dysbiosis, the Candida species were actually shown to secrete, again, a secretory IgA-specific protease activity. So the yeast themselves have their own quiver of weapons, one of which is to tear down our primary humoral immune defense, that is secretory IgA. And as with the pathogenic bacteria, the dysbiotic yeast are also subjected to in vitro susceptibility testing. And in this case, you can see that the two dysbiotic bacteria yeast were susceptible to caprylic acid and plant tannins, in which case most clinicians would use a combination of two of the agents that tested as high sensitivity. And I emphasize that at Doctor's Data, we do not use any wall charts. Every patient's dysbiotic bacteria and yeast is evaluated for its phenotypic expression, its susceptibility to both botanical and pharmaceutical agents. Now, this is to introduce the topic of parasitology. As my wife describes, one of the happiest toddlers on the planet. Not a great idea, but cute it is. Now, we use ova and parasitology, in which we can identify 50 different species of parasites. There are also enzyme immunoassays or PCR methods, but those are limited typically to only identifying 6 to 8 parasites. And those are shown in the maroon. And as I said, even with multiplex PCR, when you're simply reporting positive or negative, the parasite may have already died off, and you could just be detecting residual DNA from the parasites. So here's a case where we have a 42-year-old male who had persistent diarrhea and intermittent fever. His beneficial bacteria were good. Yeah, there were some imbalanced bacteria, but we don't treat those directly. Those can be very transient. He did not have any dysbiotic bacteria. He did not have pathogenic yeast overgrowth, but he did in fact have 5 different species of parasites, including Entamoeba histolytica. Now we also, in addition to O and P, ova and parasitology, also use sensitive immunoassays for Giardia and Cryptosporidium. And anytime you see cysts present under the microscope for a particular parasite, that's a good indication that you're going to have somewhat difficulty in preventing relapse, because the cysts are basically the egg form of the protozoa or parasite that is encapsulated in basically a concrete and steel, and it's very resistant to treatment. It's responsible for not only relapse but also transfection to other family members. Now, clinically, Entamoeba histolytica is a very interesting parasite. It infects the lumen of the large intestine. It feeds on bacteria. It may be asymptomatic, as many of the parasites are, but it can breach the mucosa and migrate to the liver in rare conditions, particularly when we have increased permeability. Now, this mucosal invasion can lead to amoebic dysentery, which is associated with bloody stool, fever, and liver abscesses. And since it's an inflammatory condition, we can check for the inflammatory marker fecal lysozyme in the stool to see, in fact, if there's significant inflammation. Now, pharmaceutical treatments for E. histolytica include paramomycin, metronidazole, and tinidazole. Non-prescriptive agents that are truly only adjunctive, as stated by the folks at the University of Maryland, they can be very adjunctive. Berberine, Saccharomyces boulardii that we're all familiar with, quasi, curcumin, and very important with E. histolytica as well as blastocystis. Limit refined carbohydrates in the diet, because they just love carbohydrates, even bread and more complex carbohydrates. So, on to biomarkers for the assessment of gastrointestinal health and function. We have quite a host of markers that really enhance just looking at the microbes and parasites. First, we want to talk about the humoral immune system in the gut, which is the first line of defense. And so we look at secretory IgA, we look at its status and its response to the presence of pathogenic bacteria, yeast, and fungi, and also very significant inflammatory markers. So for secretory IgA, I can't stress enough the importance of secretory IgA. It's 80% of total body secretory IgA is in the gastrointestinal tract. In fact, it has a very unique position in the innermost, densest portion of the mucus barrier. There, it provides the immune exclusion. It binds to antigenic epitopes of the invaders. The secretory IgA traps the invaders in the mucus, and then they are excreted associated with the secretory IgA via peristaltic and mucociliary activities. Chronic candidiasis, as I showed you earlier, can be associated with very low levels of secretory IgA despite normal serum IgA levels, because, again, of the secretory IgA-specific protease defense that the yeast carry in their quiver. Secretory IgA can also downregulate pro-inflammatory responses to pathogenic bacteria and antigens, and that's through regulation of pro-inflammatory cytokines. Keep in mind that secretory IgA can remain elevated for up to 4 to 6 weeks after a gastrointestinal virus, so it's always important, if you see elevated secretory IgA in a stool specimen, from our test result and there's no pathogens present, ask the patient whether they've had a recent gastrointestinal or acute virus. Now, it's always better to see increased secretory IgA if dysbiotic bacteria, yeast, or parasites are present. That represents a healthy immune response, and we would have a more fortified mucosal defense barrier. Now, elevated cortisol, stress, and low DHEA are infamous for decreasing secretory IgA. So it's not uncommon for us to see no pathogens present, particularly those that secrete the secretory IgA protease activity. And when you ask the clinician, is the patient under a significant amount of stress, you wouldn't believe how many times the clinicians react rather dramatically and say, yes, this patient is going through a nasty divorce or is having a very difficult time in their life. So do consider stress and cortisol, low DHEA when you see low secretory IgA. Now, if pathogens are present and secretory IgA is low or even normal, consider supporting that secretory IgA with zinc, vitamin A, vitamin D, glutamine, and DGL, deglycerized licorice root. Now, there are several probiotic strains that have been shown in the literature to increase the production of secretory IgA. One of the most commonly used is Saccharomyces boulardii, which has been shown in a germ-free mouse model to increase secretory IgA in stool by about 75%. Also, specific strains of probiotics such as Lactobacillus GG and Bifidobacterium lactis BB12 have been shown to increase the number of secretory IgA secreting cells. And that was a study from formula-fed infants. And there's likely other probiotics that would increase secretory IgA, but I like to stick to what is actually published in the scientific literature. So with our humoral immune response, our secretory IgA, again, if it's low with the presence of dysbiotic flora, consider the factors that I talked about, particularly S. boulardii, zinc, vitamins A and D. And if it's abnormally high with dysbiotic bacteria or yeast present, that's an appropriate immune response, and I would still consider supporting that so that we can maintain that critical component of the mucosal barrier. Now, nobody should have 0 milligram per deciliter secretory IgA, and there is a lab somewhere in the world that actually has a reference range that implies that it's okay to have 0 secretory IgA. I've talked to a lot of immunologists, read a lot of literature about secretory IgA, and I can find nothing to defend that it's okay to have no secretory IgA in the gut. Certainly there are very rare few individuals that have a specific inability to make secretory IgA from IgA. However, those are very rare, and having 0 is certainly not reasonable, not even realistic. So for our gastrointestinal inflammatory markers, a general marker of inflammation is lysozyme, which is a glycoside hydrolase enzyme with bactericidal properties. It's elevated in stool with enteric pathogen, very elevated during active inflammatory bowel disease, IBD. It may be elevated with irritable bowel syndrome, but that's not necessarily always an inflammatory condition. And it may be elevated with celiac disease, which certainly is an inflammatory autoimmune condition. However, the lysozyme has very poor clinical specificity for both IBD and celiac disease. So certainly not used as a diagnostic marker for IBD or celiac. So for detection of pathological inflammation, the IBDs, we use Lactoferrin and Calprotectin. The levels of those two proteins increase in stool with infiltration of neutrophils to the sites of inflammation into the mucosa. These proteins are markedly increased with inflammatory bowel disease, but not irritable bowel syndrome. In fact, the levels of these two biomarkers are very similar for patients with IBS versus healthy controls. So measuring lysozyme, lactoferrin, and calprotectin facilitates differentiation between potentially life-threatening IBD, that would be measured with lactoferrin and calprotectin, versus enteropathogen-induced inflammation, which would be represented by increased lysozyme. These markers are also very helpful to enable clinicians to monitor their anti-inflammatory clinical intervention, particularly in patients with inflammatory bowel disease. So here we have a case of a 35-year-old female who was taken to the emergency room at the hospital with severe abdominal pain. And this was 5 days after she submitted her specimens for our comprehensive stool analysis. And as you can see, all three protein markers of inflammation were markedly elevated, the lysozyme, calprotectin, and lactoferrin. And very importantly, that's clear indication of IBD, or at least highly suggestive of inflammatory bowel disease. On the other hand, when we see just lysozyme elevated and not the IBD-specific markers, that's typically associated with an enteropathogen, and we'll see very high levels of lysozyme. So very helpful in distinguishing organic IBD versus more transient pathogen-induced inflammation. Now, it's highly recommended with 2 elevated levels of lactoferrin or calprotectin 4 to 6 weeks apart that the patient be referred for endoscopy. And interestingly, lactoferrin, calprotectin never normalize with true IBD. They will be lower during remission. However, they're never as low as normal or patients that do not have IBD. So a very useful marker for IBD. This is one of my favorite cases years ago. You can tell by the older report where we didn't report as many of the commensal or beneficial bacteria. But I had a call from a clinician who was very upset that we did not provide susceptibility testing for the patient's Bacillus species at 3+. Well, we don't do that because Bacillus species are classic food poisoning organisms, and they run their course. And this was a 43-year-old male who had chronic diarrhea and weight loss for 1.5 years. So it's diarrhea and weight loss for 1.5 years, and the doctor wanted to treat the bacillus, the food poisoning. So I calmly walked him through, the clinician through the rest of the test, and sure enough, when we looked at the inflammatory marker panel, all of the inflammatory markers were lit up extensively, suggesting that this 1.5 years of diarrhea and weight loss were associated with IBD. Now, we also saw elevated white cells, which is due to infiltration of leukocytes into the lumen during inflammation, and that can be associated with pathogens, colitis, or Crohn's disease. And in this case, mucus was negative, but we also look at mucus under the microscope because we see increased levels of mucus with prolonged mucosal irritation and inflammation. or parasympathetic excitability, for example, spastic constipation or mucus colitis. Now, I can't say enough about short-chain fatty acid analysis. And short-chain fatty acids, as you know, are formed by saccharolytic, that is carbohydrate or oligopolysaccharide fermentation of soluble fiber by the beneficial or commensal bacteria, including many of the commensal Clostridia species, or Clostridium species. And these short-chain fatty acids are produced by the fermentation of stuff like inulin, fructooligosaccharides, chicory, and the root-like type of Jerusalem artichoke. Now, butyrate is of greatest interest when it comes to short-chain fatty acids. It provides the fuel for the enterocytes. They don't get fuel from systemic circulation. Butyrate also increases mast cell serotonin, which of course is involved in peristalsis and as a biogenic amine. Propionate inhibits cholesterol biosynthesis at the liver, and acetate, a third short-chain fatty acid, is a fuel for muscle and other tissues. Now, very important about butyrate is that it mediates microbial host crosstalk. That is, the body listens to short-chain fatty acids through a G-coupled protein mechanism. Now, butyrate is a major regulator of mucosal barrier integrity and function, and butyrate also mediates the release of anti-inflammatory cytokines by the epithelial cells in the gut. So when we look at short-chain fatty acids, we look at the saccharolytic fermentation products as well as the proteolytic fermentation products. And we look at those both in terms of percent distribution of total short-chain fatty acids. And people often see, this one over here in the red, and maybe this one in the red, and, ask, well, what does that mean? Well, nobody really knows exactly what any of these abnormal distributions of short-chain fatty acid mean, other than there is some significant disruption in the microbiome. More importantly is to look at the absolute concentrations or amounts of total short-chain fatty acids and butyrate, which in this case are pretty hurting. Now, it's not unusual to have very normal levels of Lactobacillus, Bifidobacter, subspecies of Lactobacillus, which are and Clostridium species, which are major butyrate producers. However, just looking at the microbes doesn't tell you enough. When you actually objectively measure the butyrate and see that it's very low, despite the fact that there is adequate beneficial bacteria that are producing the butyrate, that's very useful clinical information that tells you that the patient needs a dietary change to include more of the soluble fibers that are the food for creating the butyrate. So we also importantly look at markers of digestion and absorption. First is the elastase, which is an excellent indicator of pancreatic exocrine function, that is the production of digestive enzymes, and in this case that happens to be quite low. That's more common in elderly individuals. So that helps you focus on why this patient might have poor nutrition. We look at fat stain. Fat stain can tell us whether there's problems specifically with fat digestion and absorption. Vegetable fibers and muscle fibers really are an indication of lifestyle, poor mastication. It's not really associated with insufficient protease enzymes proteolytic enzymes, but rather the patient needs to slow down, sit down, and chew their food sufficiently. Now, very importantly, we also look for simple sugars or carbohydrates in the stool. There shouldn't be any. As you know, sugars are absorbed way up in the upper intestine, in the crypts of the microvilli, and if there are carbohydrates in the stool, that's an indication that there's significant damage or at least transient damage or flattening of the villi and the microvilli. Other intestinal health biomarkers, of course, red blood cells would indicate active bleeding in the lower bowel. That could just be associated with straining and hemorrhoids, but also looking at occult blood, which is associated with oxidized hemoglobin that occurs due to bleeding in the upper bowel. So quite different red cells and occult blood. One thing that people don't pay enough attention to is the pH of the stool. And when I see a very low pH of the stool, my first question is, how many bowel movements are they having a day? And typically the response, and we also note on the report that the stool was very loose and watery, indicating a very fast transit time. So the low pH is due to a lack of time for the colonic or luminal contents to be neutralized, and also excessive excretion of short-chain fatty acids that contribute to a lower pH. So, important add-on or follow-up tests to our comprehensive stool analysis. You can add on H. pylori antigen that we measure in stool, so we're directly measuring the antigen. Shiga toxins directly assayed by sensitive immunoassays. You can follow up with an initial elevated lactoferrin or calprotectin, again with 2 elevated results. Patients should be referred to endoscopy. Lysozyme, secretory IgA up to follow up your treatment intervention to see if you were able to bring that first line of defense back up. And also the digestive enzyme indicator elastase. We also offer a very comprehensive Clostridia culture, and that's most commonly used by people that are working with autistic children, because as you know, several Clostridia clusters have been found to be more prevalent in children with ASD. And it's really not hard to culture Clostridia, although the vegetative organism dies on nearly instantly with contact with oxygen. But Clostridia produces virtually indestructible spores that are transported to us in the transport media, and once we put those in the proper anaerobic conditions that are optimal for the growth of Clostridia, they will bloom into full colony-forming units. We also have a specific toxigenic C. difficile culture, again, because it's easy to grow C. diff if you have the right culture conditions. And when we do find positive C. diff in culture, we do a reflex DNA testing for the PALOC gene that is responsible for the production of toxins A and B. Remember, just having C. diff doesn't necessitate treatment. In fact, it's not advised. It's only when it's toxin producing, and in fact the patient has many bouts of profuse watery diarrhea per day. Also new to our quiver is the zonulin as measured in serum. As you know, zonulin is an excellent marker of a breakdown of the tight junction between the epithelial cells, so a very, very significant marker of increased epithelial cell permeability. And then also we still offer the supplanted lactulose mannitol challenge. The problem with the sugar challenge test compared to the zonulin is that the sugar test only measures the influx of much smaller particles, the size of mannitol and lactulose, whereas zonulin is more associated with the influx of larger macromolecules that are very antigenic. So my takeaway messages are really quite simple. Non-traditional microbiology coupled with MALDI-TOF MS using an expansive reference library permits identification of the greatest number of commensal and dysbiotic microbes, and it does so incredibly rapidly. Susceptibility testing is very, very important. It guides targeted clinical intervention. And remember how rapidly the antibiotic and antimicrobial resistance is occurring. Very hard to keep up with, so testing every patient's dysbiotic bacteria and yeast. The level of fecal secretory IgA provides an excellent indication of the humoral immune status of the gut and the response to pathogens. And it's an essential brick, if you will, in the mucus barrier wall. Clinical intervention for abnormal secretory IgA and its production should be considered based on this valuable information. Excuse me. Assessment of the levels of the gastrointestinal inflammatory proteins are essential for identifying and monitoring organic versus transient inflammation, and without such information, interventions can be grossly misguided, as I showed in the case where only bacillus showed up and when the patient or the clinician only looked at microbiology. Digestion and absorption markers provide valuable information about gastrointestinal integrity and function and help the clinician focus on specific clinical intervention for poor nutritional status. Not everybody needs to be on digestive enzymes. Direct, objective assessment of short-chain fatty acid status facilitates efforts to optimize the many essential functions initiated by butyrate. Truly comprehensive stool analysis provides much more objective information than just microbiology and parasitology alone, and facilitates much better patient outcomes because, after all, the more focused the targets, the more efficient your clinical success and patient satisfaction. So I thank you kindly for your attention, and for any additional information or if you have any questions, please contact us at Doctors Data at inquiries@doctorsdata.com. Thank you very kindly.